Hello, this is Joe Trahan, welcoming you to the All Me podcast from the Taylor Hooten Foundation, whose mission is to enlighten the world to the truths about appearance and performance-enhancing substances. As the national leader on this subject, they communicate their educational messages through various methods, including this podcast. Thank you for listening and enjoy the show.
Hi, and welcome to the All Me podcast. My name is Tavis Piatoli, sports dietitian with the Taylor Hooten Foundation. Today, I'm going to be your host. While nearly 70% of the United States struggle with their body weight, did you know that over 30 million people struggle with an eating disorder? Did you know that 33% of those that struggle with an eating disorder are males, and this statistic is on the rise? What factors are driving more males to struggle with body image? In this podcast, Dr. Roberto Olivardia and I discuss what are the different types of eating disorders, factors causing more males to experience them, the signs and symptoms of eating disorders, why coaches need to be careful in their approach to discussing body weight with an athlete, and the significance of having a well-rounded treatment team with the help of recovery. Dr. Olivardia is a clinical psychologist, clinical associate at McLean Hospital, and lecturer at Harvard Medical School. He maintains a private psychotherapy practice in Lexington, Massachusetts, where he specializes in the treatment of attention deficit hyperactivity disorder, executive functioning issues, and issues that face students with learning differences. He also specializes in the treatment of body dysmorphic disorder, obsessive-compulsive disorder, and in the treatment of eating disorders in boys and men. He is the co-author of The Adonis Complex, a book that details the various manifestations of body image problems in men. He has appeared in publications such as Time, GQ, and Rolling Stone, and has been featured on Good Morning America, CNN, and VH1. He's also spoken on numerous radio shows, podcasts, and webinars, and presents at many national conferences on a regular basis. We'd also like to thank our partners at Gatorade for sponsoring this podcast. Hey, Dr. Olivardia, welcome to the All Me podcast. It's great to have you here today.
Oh, it's great to be here. Thank you for having me.
You know, this is a really important topic, and it's one that we don't think about a lot, eating disorders, but really focusing on the male, because I think the perception a lot of times is this is just a female disorder, right? Males don't struggle with body image and eating disorders, but I know we're going to dive into a lot of that today, and I'm excited to learn a lot more about this topic from you.
Well, thank you for having it, and just, having this kind of conversation and bringing attention to it is what I always hope to do, and continuing to get the message out so people aren't surprised when I tell them that this is an area that I specialize in, that I still get a lot of, really? Do boys and men really struggle with this?
Yeah, excellent. Well, before we kind of dive into the actual topic itself, let's learn a little bit more about you as an individual, your background, and your career path. So can you tell our listeners about your career path and really what interested you first in the field of psychology?
Sure. So I am a clinical psychologist and a lecturer in the Department of Psychiatry at Harvard Medical School in Boston, Massachusetts. And I have a private practice where I specialize in the treatment of eating disorders as well as body image related issues with boys and men. So that can include, which we'll talk about in detail, anorexia nervosa, bulimia nervosa, binge eating disorder. I work with young males who use anabolic steroids to make themselves more muscular, compulsive weightlifters, men who have body dysmorphic disorder, who are addicted to cosmetic surgery. So basically, a lot of things that people have typically heard about girls and women, I work and have researched with boys and men. And that interest really started as an undergraduate at Tufts University, where I went to college. I took a seminar in eating disorders class because it fit my schedule. I had a little interest in the topic. I thought it was of interest to me because of this intersection of sort of popular culture and media and the intersectionality of that with the psychiatric disorder. And in that class, obviously 99% of what we talked about was with girls. And so for my final paper, I did a paper about boys and men. And this is in the mid 90s. There was virtually nothing written about boys and men. And coincidentally, two fellow college students who I didn't know too well, who didn't know each other, male students, had disclosed to me that they had an eating disorder. And I remember these are the days before the internet, going through the yellow pages and trying to help them get some resources. And all of the eating disorder facilities in the area only accepted girls. They didn't accept boys. And so I thought, gosh, where do guys go like to get help? And so that really started a whole interest of trying to fill that gap. So I did a senior honors thesis in college looking at men and eating disorders, college men in the area. And then that continued to develop into my PhD studies and culminated in a book in 2000 called The Adonis Complex, where basically all of the culmination of our research looking at boys and men, and found that this problem is a lot more common than people think. And probably not surprisingly to people, boys and men often don't talk about it and are often not only themselves, but are often under-identified by mental health clinicians, by physicians, by parents that, I think a lot of times we're trained and as we should be to be aware of how we talk about bodies and body image to young girls and to women. And unfortunately, we're not there yet in understanding how we talk about those issues and recognizing those signs with boys and men.
Interesting. Yeah, that's really interesting. And I'm assuming that your practice is not just boys in general, and the fact that it's athletes, it's non-athletes, the age difference can be all over the place as well.
Absolutely. I've worked with boys. The youngest male patient I've worked with an eating disorder is 9, and the oldest was 72. And so I have seen the range in ages. I have worked with athletes. I've worked with non-athletes. So absolutely that it could be, all different backgrounds and different reasons than different ages of onset sometimes.
So for our listeners that might just not know what an eating disorder is, let's define that. What is an eating disorder, and are there different types? And if so, what differentiates them?
Sure. So with various clinical eating disorders that you'll find in the DSM, which is the Diagnostic Statistical Manual for Psychiatric Disorders, you have anorexia nervosa, which is characterized by basically a restriction of food intake or starvation. So these are individuals who are typically going to be very, very thin or emaciated. So they're not getting in any calories. And a lot of times that restriction is due to a fear of gaining weight, a fear of fatness. But sometimes it could also be individuals who want to eat like what we call clean. So they'll say, well, it's not about weight, but I just want to eat healthy. And then it kind of spirals and gets out of control where they're almost restricting everything and anything. Bulimia nervosa is characterized by binge eating episodes. And by a binge eating episode is eating a large amount of food in a very short period of time, rapidly, impulsively, where people often are kind of stuffing, they refer to it as almost like stuffing themselves and eating like not mindfully in ways. And oftentimes that binge eating could be due to having maybe a period where they've restricted and then their body is just starving and hungry. So they eat way too much. And then with bulimia, they're compensating for that binge by purging. And by purging could be either self-induced vomiting, laxative use, excessive exercise, fasting or restricting. And then binge eating disorder, which with binge eating disorder, you may see almost equal rates actually amongst men and women. And that's the binge eating episode, but without the purging behaviors. So those are the three main disorders. Now in the DSM, you may see like to qualify for the diagnosis, you have to binge and purge, let's say X number of days and whatnot. But the majority of people might not fit those precise criteria, and that doesn't mean that there isn't a major problem. A lot of men actually that I've treated may not even come to me because they have an eating disorder. They may come to me because they have depression or they have a substance abuse problem. And in the course of our work, it becomes obvious that they have an eating disorder, and they either themselves might have had a hard time admitting it, or sometimes they're like, well, I knew something was unhealthy, but I didn't realize it was that big of a problem. But those are typically, and a lot of with those eating disorders are often characterized by a negative or distorted body image. So these are guys that might think of themselves as looking ugly, out of shape, unfit, fat, unmuscular, all of the above.
Excellent. Yeah, it's a great description. I know you mentioned binging it. I think some people might think, oh, I binge, and they might eat a bag of potato chips, whereas the true binger, I guess, is that person that might be consuming 3,000 calories in a sitting, and they're not even paying attention, right?
Oh, absolutely. I mean, I've worked with men who binge up to 10,000 calories, 15,000 calories in a sitting. And so these are often, with binge eating behaviors, sometimes are characterized where they're actually can be quite planful. So somebody who'll go and get, 5 Big Macs, get a large pizza, get a gallon of ice cream, sit down and just consume it all. Whereas other individuals might not really set out to binge, and then they start eating and they feel like they can't stop in a similar way that frankly you'll hear for people who struggle with addiction, who sometimes will say I had a drink and then that one drink led to 20 before I knew it. And whereas other people set out to, let's say, get intoxicated, you'll often see and there is a lot of correlates with binge eating disorder, with bulimia and substance abuse, that a lot of the men I treat, often some of them might be in recovery of a drug or alcohol problem and then develop an eating problem, or vice versa.
Gotcha. Let's talk about your day. Let's dive in and kind of see what does a typical day look like for you, and what are some of the types of challenges that you most often face with helping your clients work through some of those eating disorders?
So typical day is, I love what I do, and it's working with different people of different ages and backgrounds. Other than eating disorders, I specialize in other things like ADHD, attention deficit hyperactivity disorder, obsessive-compulsive disorder. I work with substance abuse, depression, people who struggle with learning disabilities. So it could really run the gamut of various different presentations. But for people with eating disorders, it could be depending on where the person is in their treatment. If someone, let's say, is in the early part of the treatment, it really is helping them almost get motivated to want to work on this problem and understand really the danger of it. Because eating disorders are, again, very similar to addiction in that there's often this conflict that people feel where they don't want to be struggling. No one wants to be struggling with an eating disorder, but it's very, very difficult because in their view, either, let's say in the case of anorexia, part of the treatment is for them to eat. Part of the treatment is going to increase calories, which means, yes, you're going to gain weight. That is the purpose. If I'm working with a young man who's taking anabolic steroids, the treatment eventually is going to be to stop using steroids, sobriety basically from steroids. And that's hard because if you stop doing steroids, you're going to lose muscle mass. And that is terrifying to some of the men that I work with. They feel that that's what makes them feel confident. And so a lot of the work at the beginning is helping understand what this problem, the eating disorder, the steroids, what it's doing for them. And for a lot of people, it could be issues around control. It could be issues around, if my body looks, quote unquote, looks perfect, then I feel more confident. Sometimes it's, really working through issues of depression or trauma and helping them understand that it's a coping mechanism, but it's not a healthy coping mechanism. And in fact, it's not going to get them to where they want to get to. In fact, it's going to make their life harder and significantly affect their health. I mean, 10 to 15% of people with eating disorders die. And half of those deaths are due to suicide, and half of them are due to malnourishment or cardiac problems and pretty significant issues that can happen, because we're talking about a psychiatric disorder, but it's also one of those that really intersect with as a medical diagnosis as well.
Well, and that actually leads into my next question. How do you, diagnosing this? Are there specific signs and symptoms that you look for that help you identify when someone has an eating disorder?
So with something like anorexia, I think with anorexia, it often can get identified quicker than something, let's say, like bulimia or binge eating, because the person is typically going to be a very low weight. That is what is expected of their age, height, and weight. But having said that, you'd be amazed at how many males that I've worked with who, despite being 6 feet and 110 pounds, let's say, that more people haven't said, is there a problem here? Like whereas with girls who are significantly underweight, they would be maybe asked by a guidance counselor at their school or parent. But it's amazing how with a lot of boys, I'm still surprised, having done this work for 25, almost 30 years now, that other people haven't asked or inquired. Their primary care physicians aren't saying, you're very, very underweight. Like, are you eating? And so a lot of times you'll look at what their food intake is, how regulated their eating is, their body image. In the case of bulimia, binge eating disorder, similarly, like looking for how much value basically they put on their body image and the way they look and their overall self-esteem. And, self-esteem is made up of all these different things. And body image is one of them. That it's not to say that, when we feel we look better, we look good, it helps with our confidence. But the problem is, if that's the dominant part of your self-esteem, then you're going to run into problems. Because if there's one thing, our bodies are going to change, especially as we get older. We're going to get wrinkles and we're going to lose this and we're going to gain a little of that. And so if that is the main thing that's holding your self-esteem together, then that becomes very problematic. And that's what you see with eating disorders, where somebody gaining a couple pounds is really drastically seen as dangerous to them, because it's like, oh my gosh, like, this is, and they really overreact to that in a way where they might then cut their food intake down. So I look for, how they're eating, how big of a role does their body image play in their overall confidence and self-esteem. I, look for behaviors like mirror checking, excessive exercise, looking at themselves, taking selfies. I mean, now with the role of social media, that there's a lot of research that shows this correlation of use of social media with negative body image. And actually with the social media research shows that it's equally impacted boys as negatively as it does girls.
Yeah, and it scares me. I have a 10-year-old daughter, and we try to limit as much of that as possible. Obviously, with TikTok and all these different things they see, it's like, oh, this is going to be a nightmare. This is going to be bad. And I try to look at the positive, but that's a very important point you just messaged, with just what people are seeing on social media, likes, dislikes, and all these things, this instant gratification. I guess that could really spark this problem and make it worse.
Oh, it absolutely has. I mean, one of the things is when we wrote Adonis Complex, that was in 2000, before social media. And if I ever did an updated edition, obviously we would have a whole chapter on social media. And I recently did a talk about what the research is, now that there's research looking at social media. And it's pretty depressing. I mean, in terms of the correlation of, even when people know that what they're looking at are filtered, photoshopped, it doesn't matter. That studies show that when you are seeing what looks like an ideal image, and then you compare that to yourself, you're going to feel bad, even if you know that image is artificial. And so it is a tough thing, because my recommendation is to try to delay social media as much as possible. I have a 16-year-old son and a 14-year-old daughter, and they just got Snapchat this year, and that was the first of the social media. And my goal was to try to get them through high school without any of it. But I Snapchat, I was like, okay, we could do Snapchat, but no Instagram, no Facebook, any of that. But I know that's not always realistic. And I always recommend to parents just to have the conversations all the time around, not just even about body image specifically, but around what makes your child feel good about themselves in general. Because what we find is that people, the boys and the men that I work with who struggle with eating disorders, a lot of time, it's an eating disorder is in a lot of ways a symptom of a bigger issue. And so oftentimes when we stabilize the person medically, then we're dealing with issues of self-esteem. We're dealing with issues of maybe a history of trauma or being bullied, or of depression, of anxiety, of social anxiety, of other things that are kind of getting in the way, that for that person, the way that they were coping with it is through the eating disorder.
Let's talk about just risk factors. You mentioned a couple of those risk factors now, with obviously with social media. Are there any other primary risk factors that you feel is driving individuals that you see to have an eating disorder?
Yeah. So when a lot of times with these questions, you'll see I often will separate like anorexia from bulimia, binge eating. And the reason is that although they're all eating disorders, they kind of are very different. They come from almost like different families. Anorexia is more what we call part of the obsessive-compulsive disorder family, whereas binge eating and bulimia are more in the impulsive disorder kind of family. So a lot of times you'll see characteristics that are unique to those different kind of families. So with anorexia, typically, personality-wise, you see people who are highly perfectionistic, highly achievement-oriented, who really have a hard time with change and with transition, have a hard time with not being in control. With a lot of the boys and men I work with anorexia, many of them also have obsessive-compulsive disorder. In fact, for some of them, the OCD is really the primary driver of the bus, and anorexia is almost a symptom of the OCD. Because even when they recover from the anorexia, we're now treating OCD. So anybody with anorexia should be assessed as to whether OCD is also in the picture. And so there's a lot of that because anorexia has a lot of obsessive compulsive qualities. Someone who's counting calories all the time, who's, looking at weighing themselves constantly. They might be cutting their food in small pieces. So it kind of fits in that spectrum. With bulimia, binge eating, typically those are individuals that are more impulsive. That's where we might see more commonly. ADHD is very common. People who might engage in substance use, individuals that might have problems with anxiety, of which food is a way for them to cope with that anxiety, to soothe themselves, to sort of ground themselves in a lot of ways. Individuals that might have a hard time sometimes feeling connected in relationships. And so they might be under this sort of thought of, well, if I look a certain way, then that'll compensate for everything that I feel like I'm lacking internally. So a lot of the young men I might treat might have like social anxiety, for example, and they figure, well, if I have the perfect body, then I don't need to have a personality in a sense. Like people, girls, or other people will sort of be attracted, to me. So a lot of times it's dealing with those things that is really the coping mechanism. And guys who often have a hard time expressing their emotions and having a hard time sort of articulating what it is that they're feeling. So even to get them in therapy can be difficult because, just in general, studies show that, men are less likely to seek therapy to begin with. And then when they have an eating disorder, they feel a lot of shame around it, a lot of shame. I think what has been helpful in writing the book, and a lot of, the patients that I work with know that they're not the first male that I've ever treated. I think that's helpful for them because they don't feel like, I always tell my patients, there's probably nothing you're going to say that I haven't heard, before, because they feel very self-conscious about it.
Yeah, you're right. I mean, having that being proud and being stubborn, and it's just like, oh, well, I can fix those things myself, right? And I used to think about that like years ago. If there was trouble or anything, it was just like, oh, I can overcome that. I don't need to go talk to someone. And then realize just talking to anybody, even if it was my wife or my friends, it's just about anything on your mind. It's like, wow, you feel so much better letting something off as opposed to letting it build, and all of a sudden it's like, boom, then it comes out. So that's amazing to see. That.
That's absolutely true. I mean, it's remarkable because with the guys that I work with, the adult men that I work with who have eating disorders, I'm sometimes the only person that they've told this to. Like I'm working with a patient now who has been married for many years. His wife doesn't know that he's been struggling with bulimia for 20 years. I mean, for certainly the entirety of their relationship plus some. And there's such deep shame because it's looked at as a quote unquote female disorder, which first of all, there's, I guess, a problem on that end. Like even just because it's associated with women, shouldn't make it the sort of source of shame for men. But the truth is it's not just a female issue, that Studies show that anywhere from 1 in 4 individuals who have an eating disorder are men. So anywhere from 25 to 30% of people with eating disorders are male. It's much more common than people think.
You answered my next question. I'm like, oh, here's the next question. My next question was, how common is this disorder in males or boys? And you said, pretty common.
Pretty common. That, some studies show that about, 30 million Americans have an eating disorder and about 10 million are boys and men. And I would venture to say that that number is higher because you're dealing with a population that vastly underreports, is vastly underidentified. And as far as research in eating disorders, less than 1% of eating disorder research is focused on males. And so even when we think about questionnaires and surveys that we look at, common ones, like there's a common one called the Eating Disorder Inventory, which lists these statements and it asks you how much you agree with them. Like an item like, I think my thighs are too fat, is something that's going to be geared more towards women. It's a female centric, because a lot of these questionnaires and surveys, when they were developed by researchers, are obviously going to be developed, normed by a female sample. Men don't have, we don't have thighs. Like, I mean, in our vocabulary, like now, if we said I'm dissatisfied with my quads, then you'll have guys who respond to that. Like, right. So even understanding that how we even reach these. I consult Harvard University has a peer hotline, which is wonderful, called ECHO. It stands for Eating Concerns Hotline Outreach. And I've been consulting with them for years because years ago they reached out to me and they said, we have female college students calling all the time about eating related concerns, body image related concerns. And we don't have many men. And we don't think it's because there aren't guys out there. We just wonder whether we're reaching out to them correctly. And so I've been consulting with them as to how to outreach to them, how to make it more normal for a guy to realize he's not the only one. And sure enough, more and more men are calling, the hotline. So to me, it's almost like when you have that information, like when someone hears, my hope is that someone hears our conversation, and some male who might be struggling, or maybe a parent who has a son that they say, oh, wait a minute, maybe we need to, get help, but ultimately to not have guys feel that they're alone in this, and that there is help and that there is treatment and you can recover from this. But if you don't treat it, it can really be devastating to you physically and medically.
You mentioned, the wide spectrum from starting as young as 9 all the way up to 73 is when you had that age range. But is there a common or an average age where someone might start to experience an eating disorder? Is it like a mean where, hey, it's normally around this time is when you commonly start to see this happen?
Yeah. So typically I would say the majority of cases, the age of onset is going to be in adolescence, around puberty. So you'll start to see whenever that individual is hitting puberty. So for boys, I would say commonly you're talking 13 to 16 within that age range. And I think in a lot of ways, with here you have puberty, which, I don't know about you, I don't ever want to revisit that time in my life. Puberty was so awkward and so weird, and your body's going through all these changes and you have no control over. And maybe there's some changes that you like and some changes that you don't like. And that could really be hard for a lot of guys. And in addition to those physical changes, there are all these social changes that come along with puberty. So now the way you're relating to, people of the opposite sex, or in the case of boys who might be gay, who are now struggling and thinking about sexuality and working with that. Now the body has this whole other identity attached to it because you're getting hormones and things like that. And so typically we see that is sort of the beginning. And with a lot of, young men that I see who use anabolic steroids, typically the age of onset for that would be like 16 to 20 would be the typical age range that I see people starting to use steroids.
I'm sure with an eating disorder, there's a lot of mental health components to this. And that's kind of one of the things when someone's struggling with an eating disorder, how does that impact their mental health? Do you find that when they are struggling that, they put more pressure on themselves than maybe somebody who doesn't have an eating disorder?
Definitely. That, it's in a way, the personality traits that lend themselves to having an eating disorder. You, again, typically like people who are very hard on themselves, who have a hard time expressing emotion, who can be very perfectionistic. And then the nature of an eating disorder just fuels all that and makes it worse. It's quite tormenting. I mean, when people, and I often will make that analogy to addiction because it's a similar sort of relationship. And I've worked with many men who have had both, and they see it very similarly, except that every single guy I've ever treated who has had a problem with drugs or alcohol and had an eating disorder, every single one of them said that as difficult as sobriety is from drugs and alcohol, with an eating disorder, there's an additional dimension to it because you have to eat. Like you can't abstain from eating. That's anorexia.
Right.
So you have to learn how to regulate this thing, that we call food and connecting to your body. And they say that can be really hard. That, with eating disorders, there's all these medical things as we've talked about, but as with your question, the psychological part of these are people that are constantly thinking about food. They're constantly thinking about their weight. They're constantly thinking about their appearance. And it's not that they want to be, they almost feel like they have to be. And so this is not vanity. This is not narcissism. Like this is someone who almost feels like tormented, like they feel prisoner of this. And so, when people do get treatment and they realize, oh my gosh, I can actually get better. It's an amazing feeling, from my position, working with people who literally feel like chains are like coming off them, like this freedom, from dealing with something like this, that a lot of them will say, I never thought that I never had hope really that I could sort of get away from this because it's just kind of with me. And especially when, for some people, because they start typically in adolescence is we're also defining who we are and our identity. And when you deal with an eating disorder at that same time, in a way, an eating disorder has a way of wrapping itself around your identity where you almost don't know who you are without the eating disorder, as strange as that sounds. And so sometimes there's this resistance, and not a resistance like a tantrum kind of resistance, but a resistance of letting it go because they're like, well, I don't know who I am without it. Like this has been a part of me and my life and my psyche, that to not have it would feel empty. And so all of these things, get addressed in treatment. And I always tell patients, it's not as unusual as you think, because some of them will think, oh, you must think I'm crazy, that a part of me kind of wants it and a part of me really doesn't. And I'm like, I totally understand that.
Yeah.
In the same way, again, when you're dealing with someone who has addiction, sobriety is not easy. I mean, especially that first year of sobriety there's a lot of changes and a lot of stuff that your body goes through, but also you have to reorganize in your whole mind. And I said, absolutely. I mean, I understand that resistance. And at the same time, when you do come out on the other side, you could be like, oh my gosh, thank God that that's not something I have to deal with, in that way.
And I've read too, where some of these individuals from an eating disorder perspective, they've had some trauma in their life, whether it's verbal trauma, verbal abuse from family about their appearance and looks, or maybe some physical trauma that has led to them to make these decisions, or not make the decisions, but just lead to what they have in regards to some of these types of disorders.
Absolutely. That was actually a big interest of mine when I started in this, is looking at the influence of trauma. And, when we deal with absolutely that, a lot of the guys that I've worked with have had experiences of either being bullied for their appearance, and bullied either for being too overweight, being bullied for being too underweight, bullied for not having enough muscularity, bullied. So that's the other difference too between men and women, is that, with guys, like I have treated a lot of guys whose eating disorder started because they felt that they were too scrawny or too skinny. And particularly the guys that I work with who end up using anabolic steroids, is that they're obsessed with gaining muscularity, something that we call muscle dysmorphia.
Yeah.
And so on that end. But in addition to physical related bullying, absolutely verbal abuse that could just, whether it's in the home, or sometimes, from coaches that they've worked with, physical abuse and sexual abuse. And sexual trauma amongst boys and men is another one of those issues that's really still under-identified. But about 1 in 6 boys are sexually abused before the age of 18. 1 in 6. Wow. And
that's alarming.
It's alarming. And unfortunately, it's 1 in 4, 1 to 3 to 4 girls have an incident of sexual assault or abuse before the age of 18. And with boys, one of the differences in terms of offenders is that what's more likely with boys than girls is it's more likely to be someone outside the home. So that could be a teacher, it could be a coach, it could be, a neighbor or something. And boys often don't report it as much as, we know from girls, there's still, because there's so much shame and that these victims have, that there's massive underreporting. That's even more true for boys. So a lot of the times when the eating disorder, again, you have to deal with the eating disorder, just like with an addiction, you have to deal with that because somebody's not in a place to really deal with those issues until they're kind of more physically stable. But the full recovery of an eating disorder is not just when the eating disorder symptoms are put to rest. It's really now dealing with what is underlying that. And in some cases, it could be really dealing with pretty significant trauma.
You mentioned earlier that 10 to 15% of people, I think if I heard correctly, will die of an eating disorder, and half of that's due to suicide, half of that's due to the physical health component of the eating disorder itself. What are some of those long-term health implications for someone who is struggling with an eating disorder? What are some things that can happen to their body that could lead to that?
Yeah. So if we, in the case of anorexia or restriction of food, one of the things that it starts to do when we don't get enough nutrients in our body, it basically just really puts our body into a major, major tailspin. And one of the things that I've really appreciated in doing this kind of work is how amazing our bodies are, like how resilient our bodies are at trying to do anything it can to survive. Like it's in our evolution to do whatever it can to survive. So when people restrict eating, it's almost like our evolutionary brain does not compute that we have food in front of us that we're refusing to eat. So our evolutionary brain assumes we're in a famine, that there is no food. So what happens if there is no food? And this is what our bodies do automatically. They shut down our testosterone. So in the case of girls, they stop getting their periods. Why? Because they could never sustain a healthy pregnancy if they're not eating. Well, boys, it shuts down their testosterone levels because evolution doesn't want those boys to reproduce because they're not healthy if they're not getting in the right nourishment. Our metabolism will slow down. Our energy levels will reduce. Our heart rate will start to change because basically it's trying to conserve as much body fat as we can because it assumes, our brain is assuming we're in this famine state, that who knows when there's going to be a food supply. So it doesn't want us to run around and do things and think about things and have relationships. It just wants us to just survive, in a very primitive way. So when we are not producing adequate levels of testosterone, that can affect your growth. It can affect your bone density, not only in the moment, but in significant cases, lifelong. I've worked with men, who may have started treatment in their 40s and 50s, who unfortunately, because of lifelong eating disorders, have the bone density of like an 80 to 90-year-old. Like if they fall once, they're done. Like in the same way that, we worry about elderly people at 80, 90. If they fall, that could be the beginning of the end in some ways. With bulimia, that one of the myths too is that it's more people with anorexia that die. There are just as many people that die with bulimia nervosa because purging, when we self-induce vomiting, again, if we look at this from an evolutionary perspective, we're only supposed to vomit if there's a toxin in our body. So if we drink a poison, if our ancestors ate a poison berry, it's supposed to vomit and then give us this rush of adrenaline so we can get to a better food source. So when somebody is engaging in repetitive purging, our brain starts to think that all food is like poisonous in some ways. Like It doesn't, again, our evolutionary brain doesn't think, oh, we're eating and we're throwing up something that's perfectly good for us. It thinks, I guess this thing must be toxic in some way. And so as a result, it really, and because when people purge, they're often dehydrating themselves and all of these things. But one of the things that it does is it imbalances electrolytes, which are chemicals that basically regulate your heart rate. And I have worked with men as early as 21, 22 who have had heart attacks because of purging behaviors. And it's not just like, there isn't even this neat correlation of if you've been purging for 5 years, you're going to have a heart attack. I've worked with people who started purging and within 3 months have had a heart attack. I've worked with people who after years and years and years might never have that. Like, right. It's like Russian roulette. Like, I mean, there's a gamble that you're literally playing, with. Now, in addition with purging, you're also burning the lining of your esophagus, which can put you at risk for esophageal cancers, dental erosion. I've worked with men who have had to get multiple dental implants because of purging, that they basically rotted their teeth, kidney problems, kidney infections, urinary issues. I mean, it basically sets all of the systems of our body that is so intricate and amazing in terms of how our body works. If we eat well, sleep well, our bodies will kind of do what they need to do. But when we disrupt that, and eating disorder is very, I always tell patients, it's like a trauma to the body. I mean, in terms of what you're doing to your body, that's not meant to happen. Who knows what's going to then result from that in the moment, as well as in the long term. And the longer you have an eating disorder, the higher the likelihood that you'll see some long-term impact.
Yeah, you mentioned the electrolyte piece. As a sports dietitian, we're typically telling people, hey, consume more electrolytes, rehydrate, all that stuff you lose in your sweat. And they don't realize potassium, magnesium, some of these important electrolytes control heart rhythm.
Yes.
So I'm glad you mentioned that low potassium level or that abnormal magnesium could really, like you mentioned, cause a fatal arrhythmia or a heart attack. That's extremely important to mention.
Absolutely. And to know, especially if, let's say, even with people who might not be purging by self-induced vomiting, but might be excessively exercising. Like, I have patients that will binge and then maybe go on a treadmill for 4 hours. And to say, in the same way, you're sweating out and you're losing, certain nutrients that if you're not replenishing. But the other thing about bulimia that's so important to underscore is that most people with bulimia are of average to actually slightly overweight. And the reality is that the more that we purge, and our bodies being what they are, is that our bodies then absorb fat quicker, because it's like, okay, if we know we're going to throw up, we're going to hold on to as much, fat as possible. So when the more that somebody will purge, the less that fat is like the fat's the last thing to go. What's going to first go is the water and all the nutrients, the potassium, the magnesium, all of those things. Because at the end of the day, in a famine, we will live longer on a Big Mac than we would a salad.
Right.
But, and at the end of the day, we're not going to be healthy overall, sure, but those calories will stretch. So when I work with people, even the education around that is really helpful, because then it's like, wait a minute. So you're telling me the more I do this, the less it's actually quote unquote effective in the sense. And it's like, yeah, absolutely. And in fact, you're messing with your metabolism now, which is going to not even burn the fat that you have because of the binging and the purging. It just disrupts all of that in that way.
Now, coaches can be very influential to an athlete. They can, in some cases, they almost can be like parental-like figures. And as a sports dietitian, I've worked in environments where coaches may advise an athlete to lose weight or gain weight or try to reach a body weight goal to accomplish a certain type of body composition. How dangerous can this type of behavior be for a coach? And could that cause an eating disorder?
Yes, I have talked to coaches, and I've worked with many athletes, and part of the treatment team, because an eating disorder treatment is typically a team approach. So I'm the psychologist. There'll typically be a nutritionist or dietitian on the team, a psychiatrist. If the person is an athlete, the coach. And I've worked with coaches that have been absolutely wonderful instrumental in my patient's recovery, because as you said, the relationship can be like a parental, mentoring, relationship. And at the same time, although I have to say this is more the minority of cases, I've worked with coaches who have been horrible in terms of instigating the eating disorder with some of the language that they talk about. Now, I'm understanding and realistic that in certain sports and in certain things that people do, that certain body types and body compositions might be. So it's not that, if a coach says, okay, if you want to run faster, I would work on this. When I talk to coaches, I just want them to be really aware of their language, what they're saying, and most importantly, in emphasizing, because they might assume that this is assumed, but it's not, that it is not by any means necessary. That if you think that your athlete, might need to lose 5-10 pounds, let's say for something, talk with them about a healthy way of doing that. And specifically say, this is not what I want you to do. I do not want you wearing a Mylar suit, doing 1,000 jumping jacks in a sauna, which is what I've had some of my patients do. I don't want you restricting food intake. I don't want you doing any of that. That's not going to help you. And really emphasize that and teach them, what are things that they can do that are sustainable, not like this diet mentality as much as, what is something that, certain habits and things that you might do, even things like sleep. Like one of the factors actually that can promote obesity is poor sleep habits and sleep deprivation. So sometimes it could be get 8 hours of sleep, and that can help regulate, your metabolism. So for coaches to know, they really do have a lot of power in their voices in terms of what they're saying to their athletes, and athletes who are, again, very achievement oriented, that have a very competitive spirit. They're going to take any feedback and they might take it to a place that the coach may never have intended them to. And that's why it has to be sort of spelled out to say, if you're going to be doing this, or if I, as the coach, think that you need to do an extra practice or an extra training, let me also tell you, I don't want you to, collapse. I don't want you to, this is what I want. And these are signs that this is too much. Yeah. Coaches actually, a lot of the great ones that I've collaborated with sometimes are the first ones to really notice the signs. They're kind of on a front line, and they were the first ones to talk to my patients and say, you know what, there's something here like that I think we need to. And sometimes for an athlete, the coach might be the only person that they might listen to, even, over their parents sometimes. And to say, or if a coach says, I can't have you be on the team until you get help with this, because there's something, this is not healthy for you. Yeah. So for coaches, just be aware of their language, and certainly not to make it about, weight per se, as much as functionality. Like if you think that, losing a certain amount of weight is going to enable somebody, let's say, to run faster or do something like that, is to talk about, what are habits that they can do, right? Like teach them, as opposed to lose 5 pounds, end of story. Yeah. It's not going to work. Here's
a number. And they're like, well, because coaches are not trained in nutrition, right? And just like exactly. I'm not trained in mental health side, although I can ask questions, but it's almost like that coach should be like, hey, go see a sports dietitian, go see,
absolutely,
go see a mental health counselor, a psychologist that can help you with some of those struggles if you're dealing with that, as opposed to that person trying to be that jack of all trades and solve that problem. But in some cases, those coaches don't have resources like that. And, I can see why they try to solve that problem on their own.
100%, because that's why a team approach is really the approach with the eating disorders, because I'm not a nutritionist or dietitian. Like I have general knowledge of what is supposed to go in someone's body, but on a meal to meal basis for that particular individual at that age with their developmental status. And that's what the dietitian, and having them on the team is so helpful for. And so, having different people on the team and recognizing, and I have talked to coaches who, as you said, they don't know where to go, for those resources. And particularly athletes that I've worked with who are Division I athletes, they feel an extraordinary amount of pressure to maintain a certain body because their scholarship could be riding on it. And so they feel like, I'm going to disappoint my parents, I'm going to disappoint the coaches, I'm going to disappoint, and then thoughts of suicide and things like that start to creep in sometimes when people feel like they're sort of just up against a wall, as opposed to, no, there are resources. And the goal, in treatment isn't you have to get out of that sport necessarily. Now, I have worked with some patients where it is too dangerous for them to be in the sport. It's just it's too difficult to regulate, but that's by far the minority. Most of the patients I've worked with who are athletes can absolutely still engage in the sport. And when they recover, they actually report that they enjoy the sport more, that they enjoy the sport better because they're actually nourished and they're healthy and they can really connect to it in a way that they couldn't before.
Yeah. Let's kind of talk about the treatment process. What is the approach to treatment when it comes to helping someone recovering from an eating disorder? I'm assuming this is not an easy process, and I'm sure it's a lot of different things, but, where do we start?
Yeah, so it really starts with, starting with, and it could sometimes be with a primary care physician or physician to acknowledge that there's something, medically wrong. And a lot of times I'll get referrals from the physician who are like, okay, the physician says I can deal with the medical aspects and monitoring blood levels and hormonal levels, but you need to talk to a therapist. Like this is not something that can just be done on one's own. Other times I might be the first person that they meet with, and then I say, okay, here are these people that I work with, and I want you to meet with this dietitian. I want you to meet with this physician whose expertise is in looking at the medical aspects of eating disorders. In the case of people that may be taking medication, working with a psychiatrist, sometimes a family therapist might be important, for particularly the young people. So it can feel very daunting because there are a lot of providers sort of in the mix, and sometimes, you're also dealing with health insurance that sometimes makes it difficult for people to get the help that they need. But it's getting kind of all of those roles in place and giving the person a lot of support. For people who are in pretty significant levels, sometimes an outpatient, which is what I do. So that would be somebody coming to see me once, maybe twice a week for 50 minutes. But sometimes people need more. So what we call either a partial hospitalization or a day program from 9 to 3, or a residential program, or in some cases an inpatient unit where they really, really need their bodies to be medically stable in order for them to even do the outpatient work. So I always tell patients, this will probably be one of the hardest things you ever do. And when you recover from this, there will be other things in life that might be big curveballs for other people that you're not going to see as big of a curveball because you would have encountered and recovered from this. And I really strongly feel this. And I tell patients that there's a lot of courage in it. And it also means that there's going to be times where they feel very fearful and times they feel very anxious. And that's all part of the process. And for them to understand that it's just really taking this one day at a time. And, as long as they're committed to it and doing the best they can with it, that recovery is absolutely possible and they could really be free from this. But it does definitely require that level of motivation to want to change and working with those various providers.
Yeah, I'm sure the recovery process, there's probably, it's going to vary per person, obviously, with the severity of their symptoms, who they are, the type. Is there an average length of time that you see that it may take someone to go into recovery or really have full recovery from this, a certain type of eating disorder?
It really can vary. I mean, I worked with someone who struggled with eating disorders for maybe 20 years, and he thought what always kept him from coming to treatment was the idea that it would take, like when he was 5 years into it, he thought, oh my gosh, this is going to take at least 5 years to undo. When he was 10 years into the eating disorder, he thought this is going to take 10 years. So at 20 years, he had lost his marriage. A lot of things happened in his life. He said, you know what do I have to lose? I mean, because he was at such a dark point. And he said, I asked him, what fears did he have or thoughts did he have about treatment? And he said, I fear that this is going to take 20 years to undo. And I'm already 40 years old and I don't want to be 60 dealing with this. And he was so committed and motivated. He met with all the providers. He did the work. And within like 2 to 3 years, I mean, I would say probably even within year 1, he was in a medically stable place. Within 2 years, he was fairly recovered. 3 years where he said like it was really not even issue anymore. Like he could eat without even thinking about the calories in it, that he could walk into a room and the first thought would not be, oh, do people think I'm fat? Do people think I look ugly? Do people, so he was amazed by that. I've worked with people, obviously the earlier you treat it, the quicker the recovery can be. I mean, and that the good news is that I am seeing people come, guys and boys in particular, who, when they do have it, are coming, maybe 2 to 3 months since it began, versus someone like 20 years ago, it'd be somebody who might have already been struggling with it for 10 years in that way. So it can really vary, but it isn't, it doesn't have to take the length of time as what they've been struggling, with it. It really does depend on the person sort of utilizing their resources and committing themselves to it, in the same way that, when I work with someone who's struggling with addiction, that, if you put the work into it, and, for people, let's say, who struggle with alcoholism, you make 5 AA meetings, they often will say like 90 meetings in 90 days. You do the kind of work, you'll see the result. I mean, it's like anything else in that way. And so it really can be, it can really vary. And then I've worked with some people who have struggled, for a long period of time. And sometimes it's because there are these underlying issues that also have to be dealt with in that.
At what point when does someone need to seek counseling, or when does someone need to see a licensed professional, for an eating disorder? I mean, I know it might be hard for them to realize they even have one, but is there a certain step where you say, hey, look, this is when you might want to, at least seek out and get some help?
Absolutely. That I would say that if you find that your thoughts are consumed a lot by what you're eating, what you're not eating, your weight, your appearance, that it's taking up so much of your thoughts. If you notice your behaviors are about, mirror checking and touching, the fat on your body, or walking into a room and being consumed by how you think other people are seeing you, debating whether you should eat this or eat that. If you feel that your sense of self-worth or value is based upon your appearance, to the degree where, like, I've worked with patients who are brilliant individuals, who are creative, who are funny, and who are told that by people in their lives. And they're like, yeah, but none of that matters because I'm not muscular. None of that matters because I'm not fit. That's a problem, because it means you're not paying attention to the things that people are actually connecting, with you on. Certainly, if you're engaging in any unhealthy behaviors, so if you are starving yourself, if you are purging, if you're using laxatives, if you're using anabolic steroids, big red flags there, that it means that what you are doing is totally contraindicated to health. Because sometimes, actually, with certain eating disorders, I'll have patients that their intent was to be healthy initially. Like, they might say, you know what, I started to cut out this, cut out that from my diet so I can be healthy. And then it was a slippery slope of cutting everything out to the point where I was eating close to nothing. And sometimes people have to realize, wait a minute, if I was starting to do this for health, I'm not healthy. This isn't working anymore. Like, I have no energy. My hair is falling out. My skin is dry. And that's the other thing, paying attention to your body, and if you're noticing, things that are off, with your body, all of those things are, signs. But I always recommend to people to always err on the side of seeking help rather than not. Because, and if let's say somebody's like, I don't know, is there an issue here? Is there a problem? You go to a therapist, and if it turns out the therapist's like, okay, this isn't this, we can work through this or whatnot. Okay, no big deal. And that way, rarely does that happen. I mean, usually when people have a certain inkling, like something might be off, they should be talking to somebody, because at the very least, even if it's at the beginning of something, you want to, if you can nip that in the bud, all the better.
Yeah, you mentioned anabolic steroids, with some individuals. What's the likelihood of, you seeing people with eating disorders, but also maybe struggling with anabolic steroid use? Is that common, or is it more on the mental health side?
Definitely common that with a lot of the boys that I work with, I mean, a lot of them will have sort of eating disorders, again, that might not fit neatly into this criteria, but their eating is quite disordered in that sense. And steroids are those things that, I mean, even today is still very under-recognized, because one, lots of people who take steroids are not going to report that they're taking steroids in research studies and things like that. But even in some of the survey studies that have been done that find that 6% of high school students admit to using anabolic steroids. So when we know that 6 are admitting to it, that there are many more that are not admitting to it. Yeah. And I remember even as far back, 10, 15, 20 years ago, working with boys. The youngest I worked with was a 13-year-old who was starting to use anabolic steroids, who got them on the internet. He bought them and they were shipped to him from Brazil. And I thought, could these be real? This was many years ago. And I thought, could this be real? And he gave them to me, which is great. And we tested them, and they were real anabolic steroids with little instructions on how to use them. And it was disturbing. And, we're living in this culture where if you look at, not only just the imagery that girls are subjected to and have been historically to look a certain way, take a look at what boys are looking at in terms of, chiseled abs and big muscles. And in the 80s, you saw this real rise in like big gargantuan, like muscle and fitness kind of dudes, that obviously were using steroids. And then in the 90s, it started to shift a little bit, where it wasn't as cool to obviously look like you were on steroids. So like we, call it like being politely roided, like the idea that you're using enough steroids to be muscular, but not too much that people like, oh, he definitely got that body, with steroids. So a lot of the men, the guys that I work with, some of them are teenagers, they don't want to look like they're using steroids, but and now, with the internet and social media, there's so much more information out there of how to do these things. Just like you see pro-anorexic, there are websites out there that teach people how to have eating disorders. I mean, to teach people how to self-harm, that teach people, it's so disturbing. And there are ones that teach people, oh, if you don't want to look like, use this steroid instead of this and that. And it's very, very disturbing. And for people to understand too, that the number one reason for anabolic steroid use, the risk factor, is not for performance enhancing purposes. That was the number one reason when they first came out. It's for body image enhancement. And so now you're dealing with people who really have body image related issues that are turning to steroids.
I'm glad you mentioned that. We mentioned that in our programs. That's the first thing, because it's like, hey, what do you guys think is driving this use, especially females and males? And most people think it's performance. It's just get big, strong, but it's really, like you said, somebody's telling them they don't look good, they don't feel good, and they need to do something to change their body image. And boom, there it is. It's the appearance side of things.
Absolutely. Because for people to understand, like with steroids, what makes it for a young male or a male particularly appealing is like, you have the substance that works from the perspective of it's going to gain muscle, like you will gain muscle. However, there's a whole host of physical and psychological consequences. And I've seen them all with patients. I've worked with, young men who have never had an episode of psychosis prior to using steroids, who start using steroids because it messes with your hormones, and psychosis of suicidality, of aggression, roid rage, of manic behavior. I mean, it messes with your mind. in addition to what we know it can do to your heart, it can do to various organs in your body. But if it's almost like we think of this as like the male equivalent of like a diet pill. Like if girls had this pill that's like, here's this pill, and you will instantly lose 30 pounds, bam, right off the bat.
Right.
Can you imagine how, I mean, but here is a substance that, and a lot of, even supplements and things like that, which sometimes cater to this market by using words like anabolic, in the title and everything to sort of, make it sort of, appealing to a lot of men. And some of these like thermogenic fat burners and everything they're basically diet pills, but they're marketed towards boys, and men. And so it's very appealing and very easy for these boys to get their hands on.
As we kind of close out, last kind of set of questions on the parent and the guardian, right? The parents, they might not be even looking for some of this stuff, or they might not be aware of what to look for. And how can a parent support their child if they're struggling with an eating disorder? Is there anything you mentioned some of the signs and symptoms, but what should the parent do?
So first is really, if they're to, look for those kind of signs, don't assume that because you have a son that he's not going to fall into, this. And I've heard from many parents over the years, and I feel for them because I don't blame them for this, but they'll say, gosh, I was always careful of how I talked about weight and body and food with my daughter. And this is for dads and moms. And it never occurred to me how my son was here. I never, ever occurred to me that my son could have a disorder. And so, to first keep an open mind about that. But also, if you're suspecting that, is, saying to your son, look, you're not the only one. We're going to get you some help and treatment. And we don't want this. This is something, because especially in adolescence, we all have adolescent immortality. Like we all think what we do is at 14, 15, we're so short-sighted. We don't think about what's going to happen to us when we're 40, and 50. And it's important to help them understand that what they're doing now to their bodies could have lifelong impact and consequences. And that's, for a parent to for the teen to understand, that's why their parent is really anxious about it, that they're not just making a big deal out of nothing, that they have this bigger picture of what this can do, to them and how they want them to be healthy. And sometimes, frankly, too, where family therapy might be helpful is it's not uncommon for a lot of young men that I've treated to have a mom or a dad that might also have an eating disorder. And sometimes the family system around food and body image is very intense around it. It's not uncommon. I worked with, I remember this 15-year-old many years ago who both of his parents were marathon runners. And the family was very big into sports, which is great to be into sports. Nothing wrong with sports. Sports are great. But it became very evident in treating him that there was a lot of other eating disorder behavior within the family that had to be addressed as well. So sometimes for parents, it's them confronting maybe their own issues around body image and things like that. And then sometimes I work with parents who have their own history of an eating disorder, who are like, oh my gosh, I can't believe this is happening, like to my kid, and for people to understand, it's not about blame. It's not about fault. It's understanding eating disorders. There is a genetic component to it, that we know that there are genes that can predispose people to eating disorders. And there's obviously the environment. There's the culture we live in. There is, family dynamics. There's whether there's a history of trauma. So there are all these variables that it's never just one thing. Like this is the one thing that causes an eating disorder. Like even when we talk about media, that it's absolutely influential in our body image. And at the same time, we know that eating disorders have also been around before social media. We just want to understand that it's multi-dimensional. But for parents to be compassionate, and particularly with their sons, sometimes I think what I hear from the boys and men that I treat is sometimes they feel like they're almost looked at as being very disturbed because they have an eating disorder, as opposed to, unfortunately, because we see it so normatively with girls, that we are like, okay, here's a girl with an eating disorder. but we don't think of, oh my God, this person must be psychotic, whereas a lot of the boys I treat, they feel that from parents, like, oh my gosh, something must be so disturbed about this individual, as opposed to understanding, no, they have an eating disorder. Clearly there's a problem there. But we don't want to pathologize them to the degree where they feel like they're so quote unquote crazy in that way, as opposed to, no, this is a problem. We want to treat this problem, and here's our resources, and we want to support you. And for parents to educate themselves too about eating disorders. And I often recommend, if they can talk, to a counselor, whether it's in family therapy or just separately, sometimes, just to know how to help support their child.
Yeah. Doc, this was an incredible podcast, incredible information. Thank you so much. Just a wealth of knowledge. And I know our listeners are going to really love everything that they've heard from this. But before you go, we have what's called the curveball round. This is where you're going to get some questions that are not related to today's topic. And it's just something fun. We do this for every guest, just to kind of keep you on your toes and see what you like and see what you don't like. All right. So my first question to all of the guests that I interview is always related to music. I'm a love music. Probably it's like sports and music are like 1 and 1A. If you could be the lead singer of any band, rock band, whatever music, who would that be and why?
Now, first of all, you're asking the right person, because if I wasn't doing what I'm doing, I would absolutely be in the music. I own over 3,000 CDs. I have been to hundreds of concerts. So you're asking the right person.
I just went to a concert. I was in Florida. I went to a concert Saturday night. First one since the pandemic. I was like, yes. I'm so excited. I'm waiting for the first one hasn't come yet. I just got tickets to Lindsey Buckingham for September.
So if I were to be the lead singer, I would say The Cure. I'm a huge Cure fan. I love The Cure.
Nice. Yeah, I've seen Pearl Jam 16, 17 times. Actually, I saw them in Fenway in, I think, 2016 and Wrigley Field twice. So yeah, we used to travel a lot. Obviously, we don't do that as much anymore, but yeah, music is just so much fun.
Oh, love music. Love it.
Tell our listeners something about you that very few people know anything about. Like, is there something like your patients would never know, or just people in general, maybe even some close friends that like, hey, I didn't know, he had those issues, he did that or enjoyed that.
I guess, well, for people who know me, they would know this, but I think if people who know me in a professional light would probably not know, and this is related to music, like I can be a pretty wild child. Like I love punk music, is actually my favorite genre of music.
Nice.
And I have been known to throw it down in like some really crazy punk shows, and where there's like people body slamming, with each other.
In the pit.
I'm in the pit. As early as a couple of years ago, I have a good friend who lives in Philadelphia. I'm in Boston. We meet up in New York, usually every summer, and he's a punk fan as well. And the last show we saw was Rancid, and it was crazy. It was such a fun show. So people, I don't know. I think people who might see me in this light might assume all I listen to is classical music, which is I like classical music, but like punk is where it's at. And then people who know me outside of work would be surprised at how deep, I'm not a religious person, but I'm very spiritual and very philosophical and can get very deep. And like, I always found myself to be somebody who, even as when I was young, was like very mature in certain ways and very mischievous and immature. I am definitely a mischief. One of my favorite words is shenanigans. Well, because I am a practical joker. I'm a little mischief. I was a very mischievous child.
My daughter's 10, and I'm taking her to see Rise Against on August the 10th. Which
love them.
I know. I'm absolutely like, I've known about them for a while. I've listened to a few of their albums, but it was about 4 years ago, I really started diving into their music, and I bought their entire collection. I'm a CD collector as well, and I don't have 3,000. I have about 600. But It's like all of their music is just so good. It's got similar sound, but she is so excited. And hopefully this Delta variant doesn't continue to kind of get crazy and expand to where it's going to cancel things. So last question for the day, and really to close out this podcast, if you could have dinner with one person, born or alive, or still with us or not, who would that be?
Oh my gosh, that's such a good question. If I had to pick one person, part of me wants to, so there are two things come to mind. One would be someone like Leonardo da Vinci comes to mind, like just as an inventor and somebody who's creative and just wanting to get a sense of how his mind worked. And then part of me would also be drawn to someone who was almost more like infamous in a negative way to try to understand where they were coming from, and in doing that, even people like that no one would ever want to have dinner with. Like I'm just interested in people in general. So, but I would say, I don't know why it's a great question. He was the first one that came to mind. And actually, I never met my mother's mother, my grandmother. She died before I was born. And my mom describes her in a way that I would describe my mom. My mom passed last year. And I would have loved to have met my grandmother, my maternal grandmother. I think she just sounds like she was a real firecracker. And so she might have been someone really interesting to have dinner with.
Absolutely. Yeah. Building relationships and just being around people. I'm like you. I love people, love music. You do all these things, and just to build those memories and relationship. Dr. Olivardia, thank you so much. This was awesome. I had so much fun talking to you today and just learning not only about your professionalism, how to help people with eating disorders, obviously how common it is for males to struggle with eating disorders. And hopefully people are going to listen to this, share this. And, and being a sports dietitian, I've seen that more with some of the kids I've worked with, and the fact that, they need to gain. That's my population. I work with kids struggling to gain weight. They're trying to gain, but then they're scared. They're scared to be like, oh, I'm 5'7", the athlete might be 5'8", and he's 120 pounds and he wants to lose weight. And I'm like, ooh, you're already, this much underweight in my head. But it's that they want to have the six pack and they're not worried about the performance side. So I think so much incredible information. I'm so glad and honored to have the ability to interview today.
Well, thank you so much for having me on. And it was a blast talking with you. And I'm always, to me, it's a mission. I always feel to just keep getting the word out, and appreciative that we have this platform to talk about this, and hope that somebody hears it and it helps them.
Well, that's it for today's show. Thanks for listening to the All Me podcast from the Taylor Hooten Foundation, a nonprofit organization leading a national campaign to enlighten people to the truths about appearance and performance-enhancing substances, and inspiring people to live and compete without the use of these substances. Please be sure to subscribe to our podcast and tune in to our next episode.